Just quickly, Tracy, that was that was completely inspiring. It really was. It was great from a nurse's point of view to hear what you had to say. That was great. Thank you. Okay, so yeah, I'm Lin Hughes. I'm a registered RMN. Got long experience working in the NHS, and I currently work within continuing healthcare, which is a complete change to clinical practice. Quite interesting at times, but also quite difficult to deliver in a compassionate way, if I'm honest, because it's very process-driven. And when I first heard about John's campaign when Leslie was talking to me about it, and listening to Nikki and to Julia this morning, I'd never heard of it before Leslie mentioned it to me, and I wondered why. And looking sort of through things and putting this presentation together, I continue to wonder why, working in the CCG, I know nothing about John's campaign. So my pledge, actually now, and I'm rambling on all the time, but anyway, my pledge is that I will take it back to our CCG and I will speak to our commissioners as well, because it's, you know, it's about delivering care not only in hospitals but care homes as well. They commission care through continuing healthcare, so it needs to go back. So take it that I will do that. Okay, and it isn't rocket science, is it? Really? And I wonder why, as mental health professionals, we just don't do it. That it isn't just there automatically, really. I just talked briefly about Jane Cummings' 6 C's back in 2012, I think. That was, compassion was the second one on the list, and it underpins, I think, everything that we as mental health professionals do. And I would echo what Julia said, I think, about the majority of people who work in healthcare are good people, and they want to help, and they want to deliver care. So, and I suppose I want to talk about things like when you first meet somebody, or when you first meet a patient, carer, in those terms that we use. We feel we're catching them at a time that is really difficult. It can be heartbreaking for them, it can be stressful, and we need to show that we understand, and we need to show that we know about the person that we're looking after. So we need to find out about that person's life, especially people with dementia. We need to know what's gone on beforehand. We need to know why they react to certain things in a certain way. So if somebody used to be in the forces, you might find they start barking orders. I've seen that in my travels on wards, you know, or if they've been in a job that perhaps they've had to be quite bossy, you know, they might start saying, this isn't being done properly. You know, if they were a manual worker, then they might be looking to fix things. So they'll start moving furniture around. And they might be doing things that is inappropriate, in inverted commas, or what might be seen as inappropriate. And we need to understand why they're doing it. And then that might give us an easier way in to being able to look after them, but also to look after their families and their friends. So I do need to use this because the memory's not good, especially something like it. So I think from the mental health nurse's point of view, looking at John's campaign, it's vital that we include families, that we include friends in every part of our assessment, and then we can understand the person that we're looking after. Now, I'm going to talk particularly around compassion, and a definition of compassion that I got out of the dictionary, I think it was the Oxford Dictionary, says that it's a sympathetic pity and sorry, this should be signed too. Oops. Thank you. Yeah, so it's a sympathetic pity and concern for the sufferings or misfortunes of others, coupled with a strong desire to alleviate that suffering. And you would have thought that all healthcare professionals would be aspiring to do that. Working in continuing healthcare in a very process-driven environment doesn't lend itself well to being compassionate. And while you can empathise, sympathise with people's situations, there's a phrase that I hear so often that makes it so impersonal, and that is, they either meet or they don't. And it's quite a shocking thing to hear, because you're talking about a person, you know, and you're talking about their family, who 9 times out of 10 are very unclear about the process, because it's what it is. And it becomes very cold and very impersonal. And I've got an example of that a bit later on. As part of preparing for this, I spoke to some of my colleagues, and I asked them what their interpretation of compassion was. Interestingly, none of my general nurse colleagues responded, but I did get responses from learning disability nurses, from children's nurses, and from social workers. So I'm just going to read out briefly what was said. Social workers spoke about empathy and an ability to put himself in somebody else's shoes, not just intellectually, but with emotion and with imagination as well. They also spoke, another social worker said, it's about caring for someone's feelings around something which doesn't directly affect you. So you're looking at somebody and understanding them without it actually affecting you. Learning disabilities colleagues spoke about active listening through verbal and non-verbal means of communication, and about stepping inside somebody else's shoes in order to understand their lives and the struggles. Also, the children's nurse was very succinct, attempting to place yourself in somebody's shoes and offering care, support and understanding. I don't know if anybody watched Ambulance last week, did they? No? Am I the only sad person? Oh, good, thank you. There was a part there where there was a drug user, homeless person who was being attended by the ambulance service and had been speaking to the operator at the beginning, and as it kind of summed up at the end, she said, it doesn't cost anything to show some compassion. There's a reason why the person's in the situation that they're in. And I thought, write that down quickly. You've got your presentation next week. So I also spoke to colleagues about what they felt the barriers were to compassion being delivered. And we're all human, aren't we? You know, we might find ourselves in a situation where we're struggling to show compassion for all sorts of different reasons. But there's also things around the lack of ability to empathise and to be able to put yourself in someone else's shoes and to imagine how that would be if that was you. And one of my social work colleagues said that a relationship with a client isn't always conducive to compassion being delivered, which I felt was very honest, really, and transparent, and very true. And we don't have to like people necessarily, but we still have to deliver care with compassion. Another thing which was felt to be a barrier was a lack of compassion within the workplace. So if staff weren't treated with compassion by managers or by their colleagues, then maybe it wouldn't trickle into the care that they deliver. And things like, you know, expected workloads, targets, all the stuff that goes on that you know you have to do can take you away from that delivery of compassion. This is looking at our watch.
30 seconds.
Is that enough? Right, so I'll move on to slide 3 then. Yes, right, it's 30 seconds. My observations from the wards, obviously I go around to various wards to do assessments. I notice things like notices at the door which say about visiting times, please don't visit at meal times. There's no opportunity for relatives to stay overnight, and often meal times and bedtimes are the hardest times the patients, but they're also really busy times for staff. So you would expect, wouldn't you, that a bit of help from, you know, someone who knows the person and perhaps settle them down or help feed them would be welcome. So that's, you know, my kind of observations from the wards are, if relatives were welcomed in to do such things, and there were set times when they could do that, then it would also help the staff and build relationships with the staff as well. Right. So slide 4 very quickly, because I've also had personal experience with my parents, both of them, but particularly my dad. He went into hospital. My mother died in April. He went into hospital in August, and within 4 months of that, we lost him. Really, he was still alive, but he wasn't the dad that we knew. And then a year and a day after my mum died, he died. So, and I think a lot of it with him was his grief, but I also think for both of them, had they had a bit of John's campaign thrown in, the end of their lives might not have been quite as difficult as they were.
Lovely. Thank you.